welcome to the Center for Digital Transformation of Health's Making Digital Health Real series. This is part of a monthly series that provides a space to explore emerging research, share career insights, and showcase projects and networks for those interested in digital health. I am Teresa. I'm a digital health researcher here at the Validatron, and we are a group of multidisciplinary um, team of clinicians and research experts in digital health. And our goal is to help de risk and accelerate digital health innovation by uncovering design issues and implementation blockers early in the phase before they impact patient care or waste resources. And one way we do this is through clinical simulation as an investigative method. We also have our very own simulation lab at the Melbourne Connect building here, where we design, prototype, and test digital health interventions in a simulated environment before they reach the real world. Before we begin, next slide, please, Victoria. I'd like to acknowledge and pay respect to the traditional owners of the lands upon which we are situated today, the Wurundjeri people of the Kulin Nation, and to elders past, present, and emerging. We acknowledge that sovereignty was never ceded, and we extend this respect to all traditional owners of the lands from which all of us here are joining today. Now, it's my great pleasure to introduce our speaker for today, Professor Victoria Brazel, who will be speaking on the topic of simulation for the real world, exploring and improving performance in healthcare. Victoria is an emergency physician and medical educator. She leads the Translational Simulation Collaborative at Bond University and is a medical director of the Gold Coast Simulation Service, where she pioneers in situ and translational simulation to build high-performing healthcare teams. She's also a co-producer producer of Simulcast, a podcast about healthcare simulation, which I enjoy listening to, sometimes
Mhm.
coming into work, and host of the Harvard Macy Institute podcast. Victoria is known um, for coining the term translational simulation in 2017, shifting the focus from where a simulation happens, such as its location or modality, to why we do it, the purpose of the simulation itself. And 6 years later, in 2024, post-COVID, there was a surge of simulation activities that happened throughout the pandemic. She then offered new insights into how translational simulation continues to evolve as a model for driving improvement in patient outcomes and health system performance. So, as someone working in digital health and clinical simulation myself, I find Victoria's work very relevant and inspiring. And Victoria's emphasis on simulation as a tool for system improvement aligns beautifully with our mission. So, I'm really looking forward to the insights she'll share with us today. And please join me in welcoming Professor Victoria Brazel. Over to
Mm.
you, Vic.
Oh, thank you very much, Teresa. And for our listeners, good to know you. Man, you did your homework. I didn't give you all that stuff. So thank you. That's high praise indeed. Thanks for the opportunity. And hopefully, this will be, I guess, what I said to Teresa was a kind of adjacent to some of the work that I think many on this meeting will be doing, but hopefully just as relevant. It's probably helpful to get a little sense of where I come from with this, and that is that I grew up as a clinician working in emergency department. And so I didn't get strong, great training in digital health or digital techniques or the kind of simulation that I suspect a lot of you do. I grew up as a clinician and then as an educator and thought about simulation in that way. So I guess a lot of the things where I might interface with this group is a little bit self-taught. So I guess I'm a little bit selfish in joining this group and rather hoping that I'll get some of the perspectives that I think are probably well known to your audience. Yeah, so that's the sort of perspective of where I'm coming from. And I think to sort of wind it back a little bit to what you said, this is often how many of us in healthcare and perhaps the lay public as well think about how we use simulation in healthcare, and that is to train and educate healthcare professionals or even just everyday lay public in things like CPR. And simulation has been very good for this. And so, for a lot of the time that I've been involved in sim, we've really thought that the method by which sim helped us improve was to make the people in healthcare better. that is good work to do. Right from teaching how to do an intramuscular injection by practicing on oranges, and then layering that up so that we practice the same injection, but while we talk to a patient about what they're about to experience and all the other, I guess, refined techniques that healthcare professionals do. And of course, now our ability to use simulation has been enhanced by many technological opportunities. Again, think about improving the skills, the knowledge, and the capabilities of healthcare professionals. And so, this is an example of practicing operating, in this case, a gynecologist. We see also that this opportunity is quite advanced. It's not just the sort of technical aspect of a skill, in this case, sort of airway management, and we have some good equipment for that. And now we have even better, sort of fancier equipment for that. But it's also about, and we're going to come back to this as we think about sim now in this translational purpose, is then thinking, well, these knowledge and skills have to be performed in context. So this is a simulation actually in our resuscitation room, with healthcare providers drawn from the teams who would be involved in this with the same monitoring, equipment, etc. So you see, as an educator, I think about have thought about sim as sort of scaffolding up from basic skills to teamwork skills to then situated capabilities. So this is, excellent work to do. And I have literally spent 20 years doing this kind of simulation where the object is to help professionals of all sorts get better at their jobs, in the hope that that also means that we get better at delivering the service. It is fair to say, a lot of that has actually come full circle. We do a lot of our simulations now with very simple modalities, practicing teamwork through desktop type simulations. And I guess one of the other themes I'm going to come back to when we talk about translational sim is not over-specifying simulations. While we're just thinking about how we do sims, and some of you probably do this as well, is certainly putting the patient at the center of this. And so this is an example of working with a simulated patient actor. And at the university where I work, our medical program simulations almost entirely with simulated patient actors that we can ask to portray certain conditions, encounters, that will then involve the medical students, obviously thinking about how they do that. So I guess I'm just painting a picture here of thinking about healthcare simulation from the point of view of most simulation people in healthcare. But then we start to think about the systems, and this is another example. Our simulated participants can be extremely good. And in this case, we were testing a new electroconvulsive therapy unit and process in our hospital. And we had a new team in a new space. All of the practitioners actually knew how to do this, but they hadn't done it together and they hadn't done it in this space. And so this was like a very nice way of thinking now, how can we take the bridge where we're not training these people how to do ECT? We're instead thinking, will the space work for them? Will the process work for them? Will the setups that we've got actually work so that they can use the knowledge and skills they have optimally to provide safe and high quality care? Because I think this is a sort of confronting thing for those of us who spend a lot of time training healthcare professionals, that we often can't make these assumptions. And one of the challenges, and I think it's probably well known to the people in this meeting, that healthcare professionals can be extremely good, but one of the things that frustrates them is that the systems don't allow them to exert those knowledge and skills because the systems might not work for them. And so I guess many of us sort of thought, well, but yes, let's just train them better and better and better, and that will eventually come over this. The reality is it's not enough. So yes, we need to train good clinicians, and we need to make sure that we've optimized the systems in which they work if we are to really realize the potential that SIM might have to improve quality and safety. So I guess this is the paradigm, as Teresa rightly said, that I think this kind of simulation is focused on, and say, well, yes, now we've got another way to improve healthcare performance through exploring. This is important, understanding, and then providing a test bed for thinking about systems and processes in healthcare. And I think one of the things that makes this clear to us as why this is important work to do is that simulation and healthcare in particular, is complex. This is a simulation, but it is a pretty good representation of what it looks like when we take a sick former patient to the CT scanner. And we could try and train those healthcare professionals to do a really good job of checking all the equipment and knowing how to use it, and that would be great. But how would we know if this is the right setup? If we should have the infusion pumps in those places? If we should have the setups as they are there? If we should put the ventilator in that spot? Or if we should have a different piece of equipment? And I guess that's the kind of thing that is hard to do any other way than by trial and error and understanding. And simulation is a much better place to do that than, I don't know about you, but I don't want to be that patient where we learn all the lessons from. So thinking about that opportunity. And so I guess this is just another way of saying this is the kind of simulation that helps us identify and mitigating risks and testing potential changes. So if we did want to alter something in that and say, well, let's get rid of the infusion pumps and just use small doses of medication as we go, because that'll speed up things and create less risk with equipment, this would be in the environment to work out what would be the opportunities and benefits from that. So again, some of these simulations can get quite complicated. I showed you a very simple one, but there's no doubt sometimes I guess can get quite complicated. And this is a simulation that we ran, really took at the interface between the ED team and the operating theatre team when we bring a sick patient up to the operating theatre. And once again, you can see that the training these people is good and not enough to make sure that all the things in their environment are working such that they can use those knowledge and skills. And in probably something that's no news to anyone here, healthcare is a complex adaptive system, and that's another whole conversation about what that is. But people have recognized this, and I guess it's worth just taking a pause about what that means. Like it's a whole complex adaptive systems theory, etc. Now, I read a lot about how people can see that, and yet I don't see much about how we operationalize improvement within that paradigm. What do I mean by that? Everyone tells me that healthcare is a complex adaptive system, and yet what I see generated in my own institution is literally hundreds of linear policies and procedures trying to describe everything that should happen in that room. So we'll have a policy and procedure about blood transfusion. We'll have a policy and procedure, and these are all linear, stepwise, complicated, often 30-page guidelines about what should happen. And then we hope that if these poor healthcare practitioners just read all these guidelines, this will come together. And I think what we know about complex adaptive systems is that that just does not work because these processes are so interrelated. And I think we have not yet found the good tools that allow us to both recognize these complex adaptive systems and arrange improvement within that. So I'd be interested in people's thoughts on that when we sort of have a little bit of a discussion. So if I was to sort of say, well, what do we mean about translational simulation? As Teresa said, it's about firstly exploring the work environment and the people in them, and that might include equipment and processes. And then if we do have something we want to try out, testing it and having literally simulation as a test bed, a sim box, as I've heard someone describe it. And, you know, in I guess a paradigm that is much referenced, this work as imagined versus work as done, it can be a way for us to say, that seemed like it was a great idea. But if we actually tried it out in process, then it's not so much. So just a couple of examples of this. This is way back, probably one of the first bits of work that I did in this regard, where we were looking at trying to get our patients from the ED to the cath lab who are having heart attacks faster. And in a way, trying to get a process to be smoother and faster is one of the easier things to do. Those of you that do process mapping know that just trying to identify things that instead of doing sequential processing, we do some parallel processing. And this was a pretty good example of that. You know, we discovered when we were doing these simulations, and we did them in situ in the ED and the cath lab of the Royal Brisbane. We simulated the patient journey. We worked with actors in this case, and those are real ambulance officers and real healthcare team members who would be looking after this patient. And we essentially went through a series of simulations that identified what were the holdups, what were the things that stopped us doing this smoother but still safe. And we managed to halve our time to cath lab for the real patients in the 6 months after these simulations. And there was no magic bullet. We just discovered all these little things, like people putting ECG dots in a spot that meant we could get the images for the up in the cath lab faster. It meant that we called through from QAS to the cath lab so that they could activate sooner. It meant our handover minimum data sets were identified, so we didn't have to spend so much time talking. It actually meant things like trust were built between the two groups, so that the ED and ambulance could call and activate the cath lab much more smoothly than waiting for the cardiologist to check and verify everything. So it was a very interesting sort of process. And I think this is a good example where just exploring the process identified many small things that improved our timeliness of care for patients who are having heart attacks. COVID was a great time to do this kind of work. These are two processes that happened during COVID that were, uh, I guess, familiar to the practitioners, but not in a way that accommodated COVID. So one is doing airway management. One is what's called proning, which is basically flipping patients upside down in ICU. Flipping patients upside down is hard at the best of times, but if they're attached to a bunch of ICU equipment, monitors, and ventilators, it's particularly hard to do. So taking the 20-page guideline that people were writing about how to do this and saying, will it actually work in practice, involved heaps of simulation. And people around the world learnt so many lessons about how to do things that were now COVID safe, either new or adapted processes, through this kind of work. And so we literally did hours and hours and hours of simulation in a month, trying to, I guess, adapt many of the processes in the hospital during COVID. So this was another good example of the work as imagined, people putting together good guidelines based on best practice, but then work as done when it said, will that really work when we're trying to think, how do we do a cesarean section in a COVID safe way? Obviously, space design is another good application of this process. This is the resuscitation bay in St. Mike's Hospital in Toronto, where they used a design thinking kind of approach and prototyping different equipment and space setups in their room through a series of simulations with their particularly doctors and nurses, but also wardies and radiographers, thinking about what would be the optimal design for people being able to access and care for trauma patients in their trauma bay. Those of you that don't work in trauma bays might think this looks pretty logical. Those of us who do know that this is the beautiful IKEA version of this, sort of nicely Scandinavian design, minimalist, compared to most of our resuscitation bays, which are full of stuff, which is more crowded and cluttered. So very nice example of using this kind of approach to sort of test, explore, evaluate, and modify infrastructure. And, some people use great tools for that. This is a bit of heat mapping that the same group used to identify best ways to do a procedure. And I don't know about you, but what this was actually testing was how long it would take people to do a critical airway procedure. And the box A that you can see up there was someone who just decided they need to look for all the bits of equipment, all in the storeroom and everywhere. And this patient, simulation, obviously, it took 6.5 minutes to get this critical airway procedure done. This person knew that there was a single kit that they had to pick up from a certain spot, and then they came and did it, and it took them less than 2 minutes. And I would rather be this person, not this person. So, sometimes people have got fancy tools and they're helpful, but not always. Lots of people get interested in this when they're moving to new hospitals and thinking about how simulation can help staff not just get used to spaces, but also explore whether the workflows they had in their old hospital are going to work in their new hospital. And this was a nice example of in Scotland, where in Edinburgh, the paediatric hospital was moving from a Victorian era kind of design to something much more new and modern. And of course, people had got used to the Victorian era design hospital, and they had all kinds of workarounds. So thinking about how the staff adapted, thinking how simulation could allow them to try just their everyday care in the new space was an important part of their transition and helping the staff adapt as well. So this has a cultural element to it as well. And I think that's important to sort of recognize these are humans in the middle of this. One other example that some of you may have been involved in is thinking about cognitive aid design. And one of my colleagues, Ben Simon, does a lot of work in this regard. And in fact, we're having a meeting after this one with someone who's about to do a PhD looking at the process of cognitive aid design and how simulation can contribute to that. This actually is one of our cognitive aids for life-threatening anaphylaxis or life-threatening allergies. In the hospital, this is basically useless if someone is about to die in front of you in the next 5 minutes. Whereas we've sort of done some work on our trauma handovers, and that same picture that I showed you, sort of working with the staff to say, what is the minimum data set if we bring up a really sick patient who needs an operation urgently? What is going to happen in 60 seconds that conveys the key information from the downstairs team, the surgical plan, and the anaesthetist. And so this is the algorithm for that handover. And this is a much more complex process than the one I just showed you with the anaphylaxis. So really thinking what is going to be useful to people, and simulation is a chance to test that. And maybe something that then is a little bit close to people's hearts here, electronic medical records. It worries people a lot about testing that. And certainly some of my colleagues, this is a group from Canada, looked at how could they think about the design and implementation of electronic health records in the perioperative space. And they used a very, obviously, comprehensive approach to collecting data, found many opportunities to help that process. That said, and I guess this, as I said to Teresa, this might be a point of discussion. This group I know took very much a simulation headspace into this, but also managed to gather some friends who knew more about human factors and some of the design factors that would make a difference in terms of electronic health records. But I think this is the kind of thing where we need to have a closer collaboration with the people who understand the kind of data to be collected here, as well as the simulation design factors. And as the way I like to think about it is with all of these things, there's a sort of in vitro testing, i.e., we all know that EMR works if you're sitting quietly at a desk and you're asking people to look at it and will it work for you. But actually, one of the things we were looking at with this was the anesthetic machines had just been integrated with the electronic health record. So really looking at what was happening over here and could the anesthetic team reconcile these two things? And I think about this as the sort of in vivo testing phase where, yes, we know the product is good, and then we think, how does it fit into the workflows in the real world? And I think those are both necessary phases of testing, and probably the sim people like me, are better at thinking about this phase of it. But one of the things that I guess I would say, and I guess I've sort of led up to this just by indicating that this is a bit hard for people who have come from thinking about simulation as an education and training modality. Uh, sure, we did some work on this and sort of did some surveys and interviews with people who were doing this kind of work. And a lot of the skills that were required for this kind of simulation was the same as we do in education. You still had to know how to write a scenario, still had to think about how to lead a conversation with the team, still had to be good at things like setting up and supporting psychological safety. But we also found that people were needing all sorts of other skills. And these are not the things that most clinicians or that most simulation educators have been trained in and sometimes don't even really understand. And yet these are the kind of things that people found were the kind of tools they were needing if they were going to answer the questions their simulations were set up to explore or test, and if they were going to analyze or collect and analyze and present data that was going to lead to truly actionable insights. Because it's very easy to sort of set up a sim and go, brilliant, this is great. We've done a big sim and people told us some stuff, but has it really led to improvement? And I think this is one of the challenges for the people doing translational sim right now. How do we either pull people with these skills into our project teams, or how do we develop some level of understanding of some of these things depending on the scope and mission of our simulation program? And some of this just literally involves thinking about how does sim integrate into the hospital. And I'm very fortunate where we work. This is a picture of the Gold Coast University Hospital. It opened in 2013, and that was the same time that we started the simulation service when we moved to the new hospital. And as such, we have been embedded and integrated into the hospital activities from the get go. As new services were starting in the new hospital, we were able to help them interrogate their processes and systems. One of the reasons we've done so much trauma simulation is the trauma service also started as the new hospital started. And that meant that there were new and a lot more trauma case mix was coming from northern New South Wales. And so it was a perfect time for us to be testing systems because they were new. And so it's meant that here we are now, sort of 13 years later, and about 70% of our simulations are actually conducted in situ in that building, not in our kind of couple of spaces that we've got that are in the education building. So it means that we have a very close relationship to the healthcare teams, a very close understanding of what their itches are, what their safety and quality itches are, and then thinking to bring our expertise about how to design, deliver, and collect data that will help them use simulation to test better ways or at least explore issues in their current work. So I think I want to just sort of emphasize this isn't all about the sim process. It is also about the sort of governance and mission and scope of your simulation program and thinking how that connects with the health service and its priorities. So, thinking back to this problem, and I guess I'm going to sort of come up to a little bit of a pause here. I've got a few more things to share, but I think this would be a reasonable place to stop shortly. And this is the sort of conundrum where I see us right now is that these are literally quotes from research papers that have been published. And I don't think this is a win. I think if you've identified 800 latent safety threats, so this is obviously problems with whatever is the process being explored, and then you haven't done anything with it, then the job is only half done. And I feel like it hasn't been done very helpfully because if the CEO of the hospital gets a lovely email saying, "Oh, we had such a great sim, we identified 800 latent safety threats, you should find someone to fix them now," then I don't know that we've really provided what I would call actionable insights that help the health service in a useful way. So I think for us, we've sort of got to the point where, and I've certainly been working on thinking about pulling a data strategy right up to the front of any of these translational sim designs. And thinking right when we're thinking, what is our problem identification? What is the question we're trying to answer? Well, firstly, thinking what data have we got to even refine the question? And secondly, once we have established what our question is, what data is going to be useful to answer it? Is it the kind of data that we can feasibly collect and analyze? And then who is going to get it and how are they going to have the resources to act upon it? So I think this is a pretty fundamental question because this was a simulation that we did prior to the opening of our new pediatric pod in the Rabina emergency department. And you can see it's a great sim. You know, we've got an actor there being the parent, we've got a mannequin being the child. They're managing a situation of a child who's got acute severe asthma. You can see they're set up in the space and they can try out and see if their equipment is in the right thing. How are we going to know if we've actually collected the right data to answer the question about is this space operationally ready to receive children as patients next week? And I think we haven't been disciplined enough about really identifying and answering those questions. So I might just sort of have a pause here if it's okay. And I have not really been following them because I've been trying to concentrate on the topics in the chat, but happy to sort of think a little bit about those for now. And then if we have still a bit of time, I've got a couple of other sort of thoughts to share.
Great, thanks, Vic. Yeah, I think we had a few people asking questions. Firstly, from Lisa, how's the patient person perspective taken into consideration?
Yeah, well, obviously that depends if that is part of what is in scope for the exploration or testing. But it was actually a really good example was that one we did in the mental health for the electroconvulsive therapy. So one of the advantages of working with simulated patient actors is they can give feedback. So that simulation involved checking in the patients, then doing that simulated ECT that you saw, then the patient going to the recovery area, which is a standard kind of process. And we kind of found a few things like there was no curtains in a certain spot and they needed more equipment here or there. But the most astounding finding from it was that the simulated patients told us, oh, when you're in the little waiting area, it's just outside the actual room where you do the ECT, and we can hear everything that goes on in that room, and it is terrifying. So, surprise, surprise, they just moved the checking in space and the waiting area 50 meters down the building. So it wasn't right next to it, but managed to do that before any real patients were subjected
Yeah,
to
that's
this
great.
experience. And I think we dodged the bullet on some morbidity there,
Yeah.
particularly for a vulnerable group of patients who might not have felt empowered to sort of speak up and so I think
Mm.
it depends a little bit. That was a serendipitous one, but in some cases, we design the sim around getting consumer feedback, often through working with SPs, but sometimes working with real patients. And I know some sim programs do much more of that, actually working with consumers both to design their sims and to help them collect data from them as well.
Great. Thanks, Vic. Lisa, if you have any follow-up questions to that, please feel free to unmute yourself. Um, I'm also inviting everyone else to pop your questions down in chat or unmute yourself, raise your hand if you want to. Um, while waiting for these questions, um, Vic, do you have a few, like about 10 more minutes to
Yeah,
of another yeah. Actually,
yeah. If
sorry,
there's no,
Lisa.
well,
Yeah,
I-
just while you're waiting for other questions to come through, by way of follow-up, um, I mean, you've just demonstrated how important the patient perspective is for this one particular example. Um, why is it not baked into every process? If there is a patient in there, um, that should be taken into consideration and part of every evaluation, even if the purpose is to look at other processes. But that there is a saying with patient advisory groups that there should be nothing about me without me. And sure, efficiency with getting critical equipment is vital, but the patient perspective always needs to be taken into account. So what's your thoughts on that?
uh, I would love to do that. And if we made that a threshold right now, we would get almost nothing done. Unfortunately, there are challenges to engaging consumers for us, and we would very soon, given the current structures, run out of opportunities to uh, allow healthcare consumers to come in, help us co-design and do things. So, as I said, I totally agree with what you're saying. And I think that's a good thing to do. And people are nudging the bar on that. But I will be honest with you and say that if we had healthcare consumers involved in every sim we did, we would have less than probably 2% of what we're currently doing. And so I think that would paradoxically compromise what we were trying to achieve for patients because it would mean that healthcare professionals weren't doing some of the testing they can do. So I think you've hit the nail on a really challenging thing for us. And I would love to think that it was different. But, we only have so much power in the SIM team, and we are still at the mercy of how healthcare consumer engagement is set up. So our working with simulated patients and participants has been one of our strongest ways of doing that, but it is far from perfect.
Yeah, thank you. Thank you. Sounds like there is a big gap with hurdles there.
Yeah, for sure. Yeah.
There is a unit at Melbourne University that is seeking to overcome that. That's a discussion
Excellent.
for another day, perhaps.
Yeah, that's great. I see Cecily's comment
Yes.
there about the people and resources. That's a great question. So we have deliberately kept our SIM service pretty small. Our health service employs about 12,000 people, but we have 4.5 of us who are in the SIM team. So there's myself who's a medical director half time, and then we have five people to job share. People with nursing backgrounds who are our simulation educators and facilitators. And we operate a sort of partnership model. So each of those people has a portfolio of different departments in the hospital that they are connected to. And so they work with them on their education, but also on this translational work, depending on what's significant. And then sometimes we have bigger projects, like we're opening a new wing for complex medical unit and patients with acute cognitive impairment, and we're doing a series of testing those physical spaces next week. And so that's something where we might come together as a bit more of a mixed team, because it's a bit of a one-off project. You'll be pleased to know we just did that with our secure mental health unit. And apropos the previous comment, like we had lived experience experts there for all of the simulations that we did, and that was extremely helpful.
Great, thank you. Waiting for more questions, but maybe I could ask my
I'm
question
happy
now.
to. Oh, yes, go for it. Yeah.
Um, so, and feel free to respond to this later if you want to talk about something else first. But like simulation and digital health, there's a continuity of the two to be converging, and it's sometimes a little bit like we probably don't know where to find our tribes to collaborate. So the question is really, how can we find each other in the space and across disciplines, sectors like us, digital health, and you're working more with probably hospitals and improvement of systems. And yeah, like how can we build the kinds of collaboration skill sets we need to really deliver real impact in healthcare and understand what data is enough, understand what data is required.
Yeah.
Thank you.
I mean, I'm always a kind of believer in doing stuff together as being one way to achieve that. And yet I know at a cognitive level, it's probably a few different layers. I think one is sometimes being on the same committees with each other, or being on the same project teams with each other. And I think that can help. And then I think just making sure that we build relationships across our organization. We work a lot on building the relationships between the anaesthetists and the emergency teams. I think we could just as easily build the relationships between the SIM team, quality and safety team, which we tried to do, the digital health team. So I think we have to all of us continually battle the silos that tend to exist in healthcare teams and healthcare institutions. So I think that helps. But to my mind, I would love it if we had 2 or 3 projects a year that we just had to do together, and then we kind of looked quizzically at each other as we discovered that we think about these problems differently, which would probably be good for both of us. So, I think the thing that where this has been stark when we've sort of thought about electronic medical records, and there's clearly a different sort of approach to thinking about how to onboard that from educators versus, in our case, the EMR vendors. So you sort of think, well, we clearly need a few other perspectives in this space as well. What I might do, because I see the question there from Mahima about approaches, techniques, on simulations that will have fidelity across a variety of socio-demographic patient groups. Interesting. And how do you go about? I might just share a couple more slides, if that's all right, because I feel like we're getting into
Sure. Yep.
some nice weeds here that is quite good. And it's going to be a combination of, so I'm just going to go that one. Nope, that one. And I will share again. Yes, on this one. Yeah. So I'm just going to give a couple more examples that maybe get to this sort of data and what we do with actionable insights. And then for different patient groups, I'll sort of come back to that. But this is a really lovely example of how simple this can be. Ava Butler is an emergency physician in rural British Columbia, and she said, when our respiratory therapists, who are designation, staff designation, we actually don't have in Australia. When they're not there, our doctors and nurses are terrible at getting their equipment ready for airway management, and that's really stressful. So she just did a series of simulations to try out different configurations of equipment, such though that it would be helpful for the doctors and nurses. And the first thing she did was introduce a trolley with a setup that she trialed in sim that would make this sort of ergonomically sensible for her and her team. And she actually did use some very nice data methods in order to explore this. So this was the time it took along the y-axis here for the team to get their equipment. And you can see at baseline, they were taking fairly long time for something that, again, is a pretty critical procedure. And as soon as they introduced the cart, that time went down dramatically. But that in a series of this plan, do, study, act, if those of you who are involved in sort of quality improvement, that's a sort of basic methodology. And they sort of got another 10% with each round of simulations that they did to try and refine this. So again, I guess it's a good example of pretty simple sim to have a high impact and to test out what's going to be helpful for the staff as they do their work. But it's also a nice illustration of some pretty simple statistical process control charts that can help you measure the impact. While we're just talking about techniques and measurement, this was actually helping the blood transfusion arrive in a timely way. And you might recognize this. Mirette Dubé was one of the authors of the work on the electronic health record. But they used a technique called failure modes effect analysis. Again, might be familiar to some people, but this is essentially just a way of sort of categorizing these latent safety threats they found according to how severe are they and how likely are they to occur. And this allows you to prioritize the things that are obviously severe and likely to occur. And so just having some methodologies by where we can deal with data that we've got is hugely important. So some of the things that I've been working on is sort of saying, well, if we've got this process for thinking about design and delivery of sims, I'm just going to step through this. I think we've got to be thinking about data right from the beginning. So as we said, we've really got to be thinking, what are we trying to achieve? And I think we often already have lots of data and measures that can help us define what it is that we're trying to work on. And, you know, Therese and I were talking about process mapping before, maybe we've done previous sims, maybe we have got staff and consumer stakeholder perceptions. And then I think we've got to say right at the get-go, well, if this is the problem, what data is going to help us? Are we going to be getting qualitative or quantitative measures? What kind of things are we really focused on? Safety, effectiveness, patient-centeredness, timeliness, etc. And can we really collect this data? You know, if we don't have a heat map technology and we don't want to do heat mapping, well, too bad. We've got to be thinking, let's not do that sim if we can't actually achieve those things. And maybe when we do all that, we kind of have to come back up to the top and go, is that really the right thing for us to be working on? Then the bit that's familiar to most sim people is, what kind of sim do we do? Is it a tabletop? Is it something with simulated participants? Is it a discrete event computer modeling? Less familiar to me, but maybe known more to people in this meeting. And often the participants have a completely different role, whether they're staff or whether they're people emulating patient experience. They're not getting feedback from us about how well they're doing. They are giving feedback to us about how the system is working for them or not. And then obviously there's various ways, and now it's so good being able to record debriefing conversations. We can now use lots of tools that can summarize those things very quickly. So we can now do lots of simulations and process this information much more easily. And then, you know, obviously then there's methods, again, maybe well known to people here, about how we visually represent that, who's going to get this data. And we can also think, was our sim the right design? And I think often we can get feedback from many people about that as well. So I know that didn't quite answer your question about different socioeconomic groups, but that can be folded into this design process. Like if we know that's important to have diverse representation of our healthcare consumers, that is kind of baked into our sim service, whether it's just simple stuff like names of people and, you know, recognizing backstories, having diverse things. They're not all Joe Smith, who is a 65-year-old retiree at the Gold Coast. There is a diverse array of backstories. So that's, I think, kind of simulation 101, I would like to think, but it's always good to have a kind of reminder. So, and the example I've got of this is we just opened, as I said, this secure mental health unit. It does look like that. It looks a bit like a luxury lodge here at the Gold Coast. Obviously, these are challenging consumer groups with specific needs, and the design was extremely well done, based on adverse events in similar units around Queensland over the last 20 years, based on people with lived experience. But then we had to think, well, sure, this is well designed, and how will it work for our team? And so we did very simple simulations, just trying to work out, will we put this person in this place? Will we, what if they have a seizure out here in the courtyard? How will we bring the equipment to help look after them? If we end up with a consumer who's barricaded themselves here, do we have the right key so that we can access this door effectively? And so answering all those questions with the team who are going to be involved, mental health staff, security staff, and then debriefing with a really wide group of people who are in this group. And as I said, we've got simulated participants, because we did some with the cardboard cutouts, some with our simulated participants. As we said, we did have some lived experience people there, and that debrief had been observing. And then we record those and then essentially put them through some AI tools that we've developed for data analysis, where we say, well, this is what we're trying to do. We put in our data from the debriefings, and then we ask for a structured report along these lines. And as you know, with AI, like 5 minutes later, it prints out this beautiful report summarizing all those things. So I think that's the sort of kind of work that